We're pleased to introduce him to talk about a topic that probably many of us miss, and he will do it including a case that he has managed. So Dr. Korir, please go ahead. Thank you.
Thank you very much, Prof. Ilako, for that kind introduction. Indeed, today's topic is one that I just thought we've never had really a discussion over. And I learned it the hard way and thought I'd share, a case and then discuss about Fuchs Endothelial Dystrophy. I'll just go ahead and share my screen. Okay, great. So Fuchs Endothelial Dystrophy is one of the dystrophies that occurs in the cornea. There's so many of them. I'll just go over it in brief, but I'll just focus on Fuchs Endothelial Dystrophy in this instance. So our main objectives is basically to define what is a corneal dystrophy, understand how corneal dystrophies are classified, just an overview, then describe symptoms and signs of Fuchs dystrophy, describe the stages of Fuchs endothelial corneal dystrophy and its management, and to be able to manage early stages of Fuchs dystrophy, and finally to be able to evaluate corneas with Fuchs endothelial dystrophy for cataract surgery. So I will start with a case that I experienced about a year ago. He's a gentleman, YH. He's a very pleasant gentleman, Asian, and he's a retired civil servant, very talkative and a pleasant gentleman. He came with a blurry vision, which was worse in his left eye. So I looked at him, his vision was 6.9 in the right eye, the left eye was 6.120. And just a quick exam, his corneas were clear, and I quickly saw he has a significant cataract on the left eye, in both eyes, but the left was worse. And in chatting and laughing, I told him, well, you do need just a cataract, which he also already knew, and he wanted to plan and get it done. So we did phacoemulsification cataract surgery on his left eye. It was a smooth surgery. Those surgeries you finish and you're happy, no issue at all. Then he comes the following day. Remember, it was 6.120 when I saw him on the left eye. And this is a picture I took just with my phone, but I took it, many months after surgery. This was his right eye, the eye that has had good vision, 6.9. And, just as you can see, quick glance, the anterior segment looks fine. Slit looks really clear on that side. And the other eye was looking like that, only that it had a cataract. If you look at the left, this was after phaco, and this is everybody's nightmare, after cataract surgery. Remember when you go on safari, you want to see a clear cornea. And this was a smooth surgery, and this happens, his vision is bad, and he's wondering, okay, so what happened? And, we couldn't, so I looked and I was very surprised. I didn't expect that. So I quickly swung my slit lamp to the other eye, and all I could see was a lot of gutty that I had missed before I took him for surgery. We'll discuss what gutty are, but they are classic for Fuchs endothelial dystrophy. So I knew he had basically decompensated after phacoemulsification cataract surgery. I kept my fingers crossed, gave him hypertonic saline, and hoped for the best and hoped that the few endothelium that are remaining were going to clear. He did clear quite a little bit. His vision improved, then dipped again, started worsening and worsened until it was at this stage when I took this photo. If you look clearly in this photo, you can see the cornea is edematous. You can see on this one, decimates folds in the cornea, a little bit of an injected eye because he's having now tearing and pain. And if you can look down here, you can map out a little bulle that is drawing on retroillumination that's showing. So it started developing this bulle that rupture and they are painful. And if you remember in anatomy, you had this intraepithelial nerve ending. So if you rupture epithelium, it's really painful. And it's a cycle that keeps going on and on. It was very torturing, just seeing him in and out every time. So I'll get back to that case, but just to get your attention that this condition is really a reality. So what is corneal endothelial dystrophy? It is a group of inherited corneal diseases that are usually bilateral, symmetrical, and slowly progressing. Those are the three main things. So if you see somebody with two bilateral, the corneas look the same, you can't explain what it is. Bit symmetrical, and then it's progressive, usually not related with an environmental factor. And sometimes you can relate it, one of their relatives might have it. So most likely you're dealing with a dystrophy. This is the same case when you're dealing with the retinal dystrophies, bilateral, symmetrical, slowly progressing, and tends to be run in the family. That's the definition. There's an anatomical classification of corneal dystrophies generally, and this is done by the International Committee of Classification of Corneal Dystrophies, and it's called the IC3D classification. And this is a publication they made in 2008 of all the corneal dystrophies up to date. And they're classified according to the layer that's affected. So there's epithelial and subepithelial, all those cases. There's a Bowman's layer dystrophies, all these cases. Reese buckler, I've seen a Reese buckler here. I think Dr. Marcos managed us for this patient as well. So they do exist, so we've had that. Then stromal dystrophies, I think we've all seen through our training some of these interesting granular dystrophies. But the ones I want to major on today is the Descemet's membrane endothelial dystrophy, and Fuchs is one of them. So that's the case there. It's a consensus to to abbreviate it to FECD, and this is just mean the level of evidence that they have to show that this is an endothelial dystrophy. They usually follow it until the genetic level. So a C1 already has its gene identified. So what is epidemiology? So most patients with Fuchs endothelial dystrophy develop the symptoms from the age of 40 to 60. That's when the onset. So 5th to 7th decade. It is autosomal dominant predominantly, or it can occur sporadically. Females are much more affected. 2 to 5 times they develop Gate, and 5 to 7 times they progress to corneal edema. So the female patients have got much more progression, so they tend to present more. There has been an early description of Fuchs, which has been reported in a 3-year-old, very rare. And in this case, they were advanced by the 4th and 5th decade. It's very rare. There's an increased incidence of primary open-angle glaucoma in these patients with Fuchs. Interestingly, we don't have any local statistics for Fuchs. So I'll just speak on my experience. I probably have seen only one African gentleman with Fuchs endothelial dystrophy. The rest of the patients that I have managed have been Asians. So I don't have any statistical backup, but I've probably seen up to close to 10 who have Fuchs, but only one African. So I don't know whether that is statistically significant. In America, from the data I read, they said it's rare in Asians. About 4% of the Caucasian populations they see for cataract surgery have Fuchs, and then it's less in Asians and Africans. So I'm betting it's a little bit more in Asians than in Africa, but it's an interesting study to maybe consider here in Kenya. So what is the pathogenesis? What exactly happens for somebody to get Fuchs endothelial dystrophy? And the primary cause of all the disease is endothelial dysfunction. So endothelium, which normally dehydrates your cornea and keeps it clear, doesn't work. What makes it not work? We don't know. Many theories, including oxidative stress, to prone patients developing these endothelial cells, which change and they become dysfunctional and become fibroblast from being hexagonal cells being fibroblast and laying down collagen fibrils in the Descemet's membrane. At the same time, the tight junctions between the cells become loose, and the result is basically a poor active pump dysfunction and a passive barrier dysfunction, and that leads to egress of fluid into the cornea, causing corneal stromal edema. So that's basically the pathogenesis. So when you look at a patient who has a Fuchs dystrophy, to your left of your screen, you have a normal cross-section of histology of a cornea. You have the epithelium there, stroma, and then a monolayer of endothelial cells. Okay, so this is normal. And to your right, you can see this other layer. You have this cornea on this side, epithelial cells, swollen, swollen stroma, and you can see this very thick layer of testament membrane because of the depositions of collagen fibrils by the endothelial cells. So this is clinically significant in the sense that when you're doing surgery for this patient, it's very easy to peel off this Descemet's membrane because it's thick and very visible, unlike the ones for a normal patient. Down here is an OCT picture of same patients, a normal OCT cross-section of a cornea, and you can see it's compact, very well organized and uniform. To the left is a patient with Fuchs endothelial dystrophy, and you can see the endothelial cell layer. The basement membrane is, a bit thicker compared to the one on the left, and there's all these bulle spaces in between. So that's a patient with the Fuchs dystrophy, and that's a histopathology. What are the symptoms that they present when they come? So it depends on the stage that they are in. So in stage 1, they have no symptoms. These are patients who just have got those guttae, or the guttae are just like small black dots that you see on the cornea, which are the collagen laid down by this abnormal epithelial cells. So you see them as little dots, and in retroillumination, you see it like a copper-bitten appearance. So in these patients with stage 1, they have no edema. They still have adequate endothelial cells to keep the cornea dehydrated. But if you examine them, they have a moderate guttae. Usually they start in the center, and they will have good vision, 20/20. In stage 2, now you're starting to have a little bit of edema into the stroma. So it's not painful because you're not having bulle, and they have a little bit moderate, reduction of vision. Because of obviously the cornea being affected, a little bit of glare, vision slightly affected 20/20 to 20/80. Then stage 3, you start having pain. So what's happening now is that you're having more and more fluid, and now it's causing epithelial edema and formation of bulle. Okay, so if you look at the guttae in these patients, they are larger, and there's more edema, and they will have episodes of bursting of that epithelium, and they develop these cycles of pain on and off. The vision will be a little bit more significantly affected than stage 3, but this is a painful stage that patients will tend to present in. And then stage 4, after a patient goes through these cycles of bulle rupturing on and off, the epithelium heals by forming scars. And therefore, it becomes such a tight formation. The epithelium is tightly adherent to the basement membrane, such that you're not forming bulle anymore. And they become comfortable. Although now, because they have a scar, they're not able to see. So their vision will be very bad, but then their scar has really formed. This is similar to the same cycle patients go through when they have pseudophakic bullous keratopathy. They are very symptomatic initially, then they just scar and they stopped having pain, but they're not seeing very clearly. So those are the stages and the symptoms. So patients will present on any of those stages. So I'll just a few pictures to show you how it looks like. If you do a slit beam or a paralleloid, you will see the posterior part of the cornea. You see those little small dots there. It's a lot easier to see it on the slit lamp. But if you get into the habit of just examining the back there, not just the cornea, and you move it a little bit, sometimes they appear shiny, and then you focus, and then you see some abnormal appearance of the endothelium. It's very easy to spot it. It's more in the center. So you can see this is a much more magnified picture on the right. So this patient is probably in stage 1 because there's no edema. This is just a retroillumination. For you to see, you can see all these little dots appear like a copper-bitten appearance. What you can do to get a good retroillumination, you can either use the iris, bounce the light on the iris, and you'll examine the cornea, but it's much easier to bounce it on the retina and then just examine your cornea. And you see it lights up very easily. So this is just to demonstrate retroillumination. More retroillumination on this case. This one on the left, and to my right is a patient who's had, subsequent on This is more stage 3, where you have now fibrosis. So there's subepithelial fibrosis already, which you can see on this patient. This is a case, this is probably stage 3. You can see a lot of edema here. With an eye of faith, there's a bulla here, probably ruptured. So this is stage 3, painful stage. This is stage 4. You can see subepithelial scarring, maybe a few bulla here. But this patient is not in pain compared to this other one. So those are roughly how the patients look like. So how do we investigate, Fuchs dystrophy? You can do a confocal microscopy, as you can see here. And this is just a microscope, basically. It's like a live microscope that you can examine each and every layer of the cornea, starting all the way from the endothelium, stroma. You can see it live. And it's very useful in assessing a lot of cornea pathology. It's just like histology of the cornea, but live. So it is costly. Where I trained in India, it was just the main center that had it. But the rest of us used a specular microscope. So it is better in a setting of cornea edema because you can still look at the images because of how they put the lightings. You can examine gate. You can assess pleomorphism, which is basically variability in cell shape. And then polymegathism, which is variability in cell size. And this tend to tell you a little bit of abnormality, because you remember, if you lose an endothelial cell, what happens is that the rest of the cell are spread out in order to cover the deep place where there's no epithelium, and the rest enlarge and forming polymegathism. Some start varying in shape because of pathology or anything. So it's very good to assess these two things when you're looking at endothelium. And finally, you can see the endothelial cell density in your patient to be able to assess whether you have adequate endothelial cells. So that's confocal microscopy, very useful, but very expensive. A little bit more, within the price ranges. This specular microscopy, also not very technical. Confocal needs an ophthalmologist to look, it's like looking through a histology slide. A specular microscopy, it's a gadget. It's just like an autorefractor, very easy. A technician can take the photo and you assess it. It has very good figures that is able to help you assess the cornea. Cost effective, easy to use. You can assess gate, you can assess pleomorphism or polymegathism. You can see your endothelial cell depth, density. So this is a little bit an easier and much easier to reach equipment. Finally, you can assess the cornea thickness using any pachymeter you have. The specular microscope has got its own pachymeter, and also most of the machines that we use, you can use just the ultrasound pachymeter, whichever you have, to assess, because you can know the thickness of the cornea by just looking at the central thickness, and tells you the grade of Fuchs. All right, so I have just pictures of specular microscopy of some of the patients. And I'll just try and keep it very simple. Just remember, a normal endothelial cell is hexagonal and it's supposed to be uniform. More like this little layer here. This is a mosaic of the endothelial cells of this patient. In a specular microscopy, you can do the center, top, down, right, left, but the most, as I said, Fuchs affects the center. So you want to assess right at the center of the cornea and look. So it's a healthy patient. So, you can see that mosaic, very uniform, hexagonal, looks like honeycomb. And then look at the graph up here, which is going to help you assess, the size of the endothelial cell, okay? And also able to assess for you the shape of the endothelial cell. So what this machine does is that it counts the apices of the endothelial cell. So hexagonal just has 6 apices. So if you look at under the number 6 there, you have a big spike. So it tells you most of your cells are normal. And if you look at the shape of this graph, it tells you most of your endothelial cells are not, within a normal range, 200 to 600 there. And, so this measures more of a polymegathism, and this measures polymorphism. So basically the shapes, this is for the sizes, and this is more for the shape. As you go through down this graph, generally, if you look at that endothelial cell, which is normal, I've tried to put patients in worsening, condition. You just look at the endothelial mosaic. It's getting worse and worse and worse as you go until there's no proper morphology. So if you look back up here again, if you look at the apices, looking at the polymorphism, this one is, most of the cells are around 6 apices. It spreads out until, you know, there's a big variability in the cell shapes, big variability also in the cell sizes. So this generally tells you whether you have an abnormal or healthy epithelium. There's some indices also here which can help you. Just basically the endothelial cell density. This is a healthy 3,000, you know, and as you go down with the graphs, this endothelial cell density reduces. One of the other critical things when you're looking at this, apart from this morphology, is these dark spaces that are inside the endothelium. And these are what those excrescences or deposits that are formed by the epithelial cells, endothelial cells look like. So they start, you know, as little black dots. They enlarge into almost the size of one cell, size of group of cells, large ones, and you're having shape of endothelial cells becoming abnormal and more abnormal. So this gutting can be graded depending on the stage of Fuchs. So basically, you can clearly see how this pachymetry is very useful. This specular microscopy is very useful. The other thing that it does is it measures the pachymetry, the thickness of the cornea. So as you go across these corneas, you know, they get thicker, not very good. Actually, a lot of people mention that this pachymeter from specular microscopy is not as accurate. So you're better off using an ultrasound probe. So
Yes,
that's it. So how do we treat Fuchs? So again, it depends on the stage that the patient presents with. But most of the time, so the early stages, you can use hypertonic saline or 5% sodium chloride 4 to 8 times a day. As obviously these drops are hypertonic, so they sting, and they're, you know, patients are not comfortable because the whole mechanism is to try and draw out the water from the cornea. So they are not pleasant. There's also an ointment which you can put at night so that by the time they wake up, at least it's dehydrated. The symptoms of Fuchs are worse in the morning because they've had their eyes shut when they're sleeping and there's no much tears evaporating on the surface. So what happens is that now you have more edema. So some people say you can use a hair dryer at arm's length, okay, and then just blow gently on your eye so that it dries out most of the air. So that's one of the conservative treatment. You can lower IOP so that you reduce the fluid that is pushing through the cornea. But I would say do not use carbonic anhydrase in these patients. You better using latanoprost and prostaglandin analogs, timolol, all this, but avoid carbonic anhydrase because you already have a compromised pump system. You could use bandage contact lenses to flatten the bullae in those patients who are symptomatic so that you protect the exposed nerve endings. So these are more symptomatic management. Surgical options in patients now who are in stage 3, because already you are having a lot of pain, you need to deal with the cornea now at that stage. So what do? Actually, you can just replace the thick part of the cornea, basically, so that you want to replace the endothelial cells. So you can do that by using Decimet's tissue, and most of the eye banks are able to cut for you. So this is Decimet's stripping automated endothelial keratoplasty. So basically, you get a cornea which has got the back cut out. So you harvest it, you peel it out, and then you do surgery and insert to the back of the cornea. You remove the thick endothelium and you place this inside. Down here is a picture of a patient OCT showing the endothelial keratoplasty here. It's a very quick surgery, and it gives very good results. You don't have stitches to deal with later on, and the patient vision improves and they're comfortable. It's really become advanced in this field of endothelial keratoplasty. The latest is DMEC. This is a very thin membrane. It is just the Decimet's membrane endothelial keratoplasty. So with DSEK, you have a little bit of stroma, but with DMEC, it's just the Decimet's membrane alone. So it's very thick, very thin and very difficult to handle. So I guess you have to be a very good DSEK surgeon to do a DMEC. There's also an in-between, it's called a PDEC, which is a pre-Decimet's endothelial keratoplasty. I think this came after, if you remember, Dua's layer. So I think it's at the Dua's layer where they peel off that endothelium using bubble technique. So anyway, just know that there's endothelial keratoplasty. The easiest here would be a DSEK for most patients. If the patient has got subepithelial scarring, there's no way you can replace the endothelium only, because now subepithelial scarring is way up there just below the epithelium. So you have to replace the whole cornea in this case. So if a patient is in stage 4, you just have to do a full BKP for them to see. I have a video here for DSEK. It's a 1-minute video. So I'll just indulge you on the steps that we do. Just a second. Very sorry. Okay, great. So if you know small incision cataract surgery, it's pretty much the same, but in this patient, you're doing temporal incision, then you do a frown incision, make a little tunnel on the side, and then enter with the keratome. This is about a 6 millimeter wound, so that on top is just marking the cornea just to guide him so that they center the graft. You take a reverse Sinski, and then you peel off the decimates from the back. And if you can see, it's very easy to see the decimates membrane. And you bring it all together. You just go around that area where he's removed. So you peel it out, just like when you remove the capsule. Then you widen the tunnel. Is removing the viscoelastic. This is a patient already who had cataract surgery. That's how you load your decimates. There are many deliverable things you can use to deliver it inside. Or you can just fold it like a taco, and then you put it inside. You have to tap it a little bit and balance it. Finally, you put an air bubble real tight for about 10 minutes. So that the endothelial pump starts working. After 10 minutes, somehow it tends to be well attached, but you leave an air bubble about maybe 30 to 60%, just so that you hold the endothelium. You advise the patient to lie facing up. Preferably, if you could admit this patient so that you just monitor them so that they're just compliant, because the main complication with this surgery is detachment. Once you put it in there, sometimes it can come out. So that's the main thing, and you have to go back and rebubble. So at least you can keep the patient for some time, at least for the epithelium to wake up and start pumping. Once it gets stuck to the cornea when the pump starts working, because of that negative pressure that it creates. So one of the things that you look at the end of the surgery is this double ring. Just get a good picture. You get this double ring, and this tells you that you have gotten your endothelium tissue well positioned. And sometimes you have a letter written here. It can be an S, it can be an F, which tells you that this is in a good position. So that's endothelial DSEK surgery. Recently, there have been people who've been advocating for something called a DWEC, a descemetorrhexis without endothelial keratoplasty. So what happens is that in these patients, the pathology, the idea is the center of the cornea is where the disease is. That's where you have the abnormal endothelial cells. So what if you peel out those endothelial cells and leave the healthy cells around it to come and grow and replace it? And this has actually been shown to work. And but for very specific patients. These are patients who have the presence of central gutter deemed to be the chief cause of their visual complaints. They have a clear peripheral cornea with an endothelial cell count of about 1,000 cells per millimeter in the periphery. Then these are patients who you are otherwise contemplating to do endothelial keratoplasty, so that if it fails, you can, the patient knows that you need to still do endothelial keratoplasty. It can be a phakic or pseudophakic patient. Contraindications would be an advanced corneal stromal edema, peripheral endothelial cell count of less than 1,000, presence of secondary pathology, or history of herpes simplex or CMV keratitis. So those are the contraindications for a DWEC. But it's a very simple surgery compared to a DSEK, because you're just peeling the center, and it's a very quick one. So that's what makes it a bit attractive. So what happens in our setup where we hardly have cornea tissue? You have this patient in stage 3, painful eyes all the time. What do we do? Some of the things that you can do is anterior stromal puncture, and I think sorry, just get a pointer. So anterior stromal puncture, basically you peel the cornea and just make a little bit stromal punctures, just on the anterior stroma. Make little, you can do this on the slit lamp. I try to do it in theater more, just for patients' comfort a lot of times. And this we do also for patients with pseudophakic bullous keratopathy, and you don't foresee yourself being you don't have a cornea tissue anytime soon. But once you do this, the patient develops scarring. It's like basically fast forwarding the patient to forms of epithelial scarring, so that you give them comfort as you wait for cornea. For those patients, you're eventually going to need, penetrating keratoplasty because of other reasons why you can't do a DSEK. You can do Bowman's membrane cauterization for the same reasons, fast forwarding them to the stage 4. Some people have done corneal hooding just to cover, give them comfort to cover those endothelial nerve endings. And some people have tried amniotic membrane covering. So I think the biggest dilemma is, what do you do in a patient who have got Fuchs endothelial dystrophy and they have cataracts? And this was, I might put it this way: if I had seen this gentleman that we operated on earlier and actually noticed that he had Fuchs, what would I have done different to prevent what he developed? One is to do a specular microscopy and pachymetry. That will guide me, because when you do these two, it's able to tell you who is at risk of decompensating, or who should you do. And then those are patients who are at risk of decompensating. You need to do endothelial keratoplasty and cataracts at the same time. Some patients with lower risk of decompensating, you can go ahead and do your cataract surgery with precautions. So if you do a specular microscopy and you have your endothelial cell density of less than 1,000, do not do cataract surgery alone. Do combine it with endothelial keratoplasty. A cornea thickness of greater than 640 microns, you do endothelial keratoplasty as well. And if you have epithelial edema. So these are the three things that are recommended on several publications on what to look out for. Just to have microscopy. And if you have any of this, do combine it. So what if a patient, you've done it and they do not fall into any of these categories? What do you do? Do I do phaco? Do I do small incision? The answer is you can do either, but you do the surgery that you're most comfortable with. I can be a phaco surgeon, but I'm still learning, which means I use a lot of energy. And I can be a very proficient small incision cataract surgeon who uses very minimal endothelial touch. So choose a technique that you are very comfortable doing. And then the other thing is you need to also assess the cataract itself. If the cataract is very dense, even if you're a good surgeon, sometimes it might be better to do an MSEK if you're having an NS4 or really thick cataract. So it depends on the density of the cataract, and how proficient you are in which technique. But either technique has been shown to be, safe in the patients that, fall into this category. When you do surgery, also during the surgery, you need to, try and use a soft shell technique, which means you want to combine a dispersive viscoelastic and a cohesive OVD. I have a diagram here on the left, and when you're doing a cataract surgery, this is a patient you want to be very generous with your viscoat or any dispersive viscoelastic. So I think in the market we have viscoat and many others, and then you have this viscoadaptive of cohesive ones. These are like Helon, Provisc. Helon and Provisk. These are the ones that basically sodium hyaluronate. Anything with sodium hyaluronate tends to be quite cohesive, and it can, and that sits on the center and forms for you the AC. While you have this coating that goes around the endothelium and protects it much better. So you want to use this soft shell technique, whether you're doing a small incision or you're doing the other cataract. Unfortunately, some of these good OVDs are quite expensive, but in these patients it's a lot easier, better to sacrifice that cost than go through the patient's discomfort. The other thing is you want to use BSS over ringus lactase. BSS has got glutathione and also many other things that are much more physiologically close to the aqueous. So you don't want to take chances with any other fluid. And then so that's when you decide to do cataract surgery. If you put a lens, do not put multifocals or these other lenses, because you're going to be disappointed. Better to just use a simple monofocal IOL. These patients, when you do a combined cataract surgery and endothelial keratoplasty, you also want to target an IOL of -1.25, because when you put that little endothelial, when you do a DSEK, you sort of get a hyperopic shift. So you want to give a patient target a -1.25 whenever you're doing a cataract surgery. So those are some of the tips, and maybe those are the things I should have considered in this patient when operating. So what happened to him anyway? So after several years, months actually, he decompensated, he improved. Remember he came in 6/120. He came in, he was 6/22/400. That's about, he remained the same vision, but now cloudy. And then it improved slightly, then it became worse. Then it decompensated this way. Went to stage 3 of Fuchs, started developing this bulle, very difficult case. Luckily, we managed to get managed to do DSEK for him about 2 months ago, and not a great picture, but this is how he is. This was how he was, and you can see the difference. That his vision improved to 6/120. At least so far, I've taken him to 6/120. Maybe if we refract him, he will improve a little bit more. But what is most important, he is comfortable. So that is how he looks now. This was the temporal stitches that we used when we operated on him. It's much comfortable. His vision is improving. I did an OCT for him, and you can see how well opposed that the DSEK tissue is at the back there. And he has still had some epithelial bulle, but I do think that this will clear over the next few months. So that's our patient. So he's doing well. This is another case of a DSEK. I just wanted to show you how it sits at the back. This is not mine, but a picture I got from when I was training. So this is cornea just sitting at the back. You can see no stitches that your traditional PK looks like. And these patients recover remarkable. And you can see that lenticule sitting at the back there. So once it is integrated, it's a lot easier to deal with. And it's very satisfying surgery. So in summary, we have defined what corneal dystrophy is: progressive, symmetrical, family, tends to run the family. We've seen how they are classified according to anatomical layer. We've described signs and symptoms of Fuchs depending on the stage that they are in. We've described some of the management, and I believe you can be able to manage early Fuchs dystrophy for now, and you'll be able to evaluate your patient better before you do surgery and end up in a pitfall like I did. Thank you very much. I think that's my last slide. I would recommend the community eye health read. So just Google cataract in patient with Fuchs. I think this is a really good read if you want to revisit most of what I've talked about. Thank you.
Thank you very much. Thank you very much, Dr. Korir, for a wonderful presentation. And I think it's a wake-up call for almost all of us. Many times we do fantastic cataract surgeries, but the outcome is so bad. So you wonder what happened, what went wrong. And I think it's because we don't really look at our corneas very well. And just by a show of hands, or maybe on the chat box, how many people do specular microscopy or endothelial cell count before cataract surgery? It would be nice to know, because that would probably help a lot of us as we go forward. Just a question. Let's say you have the Fuchs Endothelial Dystrophy together with cataract. And I know you have said it depends on the kind of method that you prefer. Would you advocate, you've seen now it's Fuchs, maybe stage 2. Would you advocate do early cataract surgery? Would that help at all? Or it doesn't really matter?
Good question. If I got you correctly, you're saying somebody's at stage 2, they have an early cataract. Would I advocate for surgery or not?
Yes.
Okay.
Early, advocating for early cataract.
Oh, early cataract. Well, that's a really tough question. I think it's discussed with the patient, having looked at the risks, whether a patient is going to decompensate or not. Because an early cataract, I'm guessing you're saying early cataracts, you're going to lose less energy. This lens is going to come out easily. And anyway, Fuchs is going to be progressive.
Yes.
So do you want to get this thing out early or not? I think it's not one of those things you discuss with the patient. Tell them, look, this is your condition. And, and also depends on their visual needs. If it's a patient who is pretty old and, their visual needs is not that demanding, I really want to stay away from this patient, quite honestly. I try to avoid operating unless I really must. And if I must, then you have to tell them, the risks that are involved, try and take your precautions, if their vision is really affected. But an early, that's a challenging question. I don't know. I guess you have to discuss with the patient.
But what are you going to discuss with the patient? Because you would still have to, okay, it's a catch-22.
Yeah.
But okay, we're encouraging everybody to put their questions on the chat, or if anybody wants us to unmute them, unmute yourself so that we can discuss, or you can ask your question. Angela Mokaya is asking everyone, thanks, Dr. Korir, where is the specular microscopy available?
Okay, thanks, Dr. Mukaya. I think that I'm only aware of 2 in the country. I know Dr. Beth in Eldoret, and I think Professor Ilako has one. And that's probably why we chose her here, so that she helps us know what to look out for, what her experience has been. I'll also throw a question. What has been, has anybody else seen these Fuchs in this country, and what are the epidemiology? Is it Asians like I have seen, or some other people have seen other patients? Prof, maybe you can contribute as well.
We also have a specular microscope at CTI.
Oh, great. That's good to hear. Maybe anywhere else, if somebody has, they can tell us.
So at least there are 3 specular microscopes. So are people using it? At least for us at Eagle Eye, it's only the patients that come to Eagle Eye that we use. So maybe the others go elsewhere. But I think it's time that people really look out for this and use it to know your outcomes. And I think the other thing that we probably are not using very well is the OCTs. The VRs like Ibata have come many times, so you keep talking and you think OCT is only for the back of the eye. How many people use it to check the cornea? So I think it's time that we also, rethought about how we use our OCTs. Dr. Korir had put a question to everybody. I'm trying to see. Okay, Lions has one. So there are many here. So in Nairobi, we already have 3. Yeah, okay. I don't see any other question. Please, anybody else? The only thing is, I'm wondering, because many people do penetrating keratoplasty, but most of it is probably due to keratoconus. And yet we're told worldwide Fuchs endothelial dystrophy accounts for almost 20% of the corneal grafts that are done. But I don't know whether we don't have enough data here. Is it that it is not available, or is it like it's not, I mean, it's not there, or is it that we have not looked out for it?
Prof, I think it is possible that there are patients that we operate and then they decompensate, and then we say probably it was our technique or something, or we just explained it somehow. But maybe we don't have that index of suspicion, or not very comfortable in identifying the GATE, and we end up missing a lot of these patients. Maybe it would be interesting maybe to look at it retrospectively. These patients who decompensate after cataract surgery, what actually caused them? These patients are calling pseudophakic bullous keratopathy. Could they just be Fuchs?
I can see Dr. Nyamori here. They did a study. Okay, Kibata, go on. Go on, Kibata.
No, I was going to raise the same issue, so it's fine. It just struck me that we see a lot of pseudophakic bullous keratopathy, and you tend to think, oh dear, probably the surgeon struggled. But now in retrospect, I'm just wondering, I think every pseudophakic I'll begin doing a specula in the other eye, because you just wonder, is it really technique, or was it just all Fuchs and just a cataract surgery caused the decompensation? The other problem is that by the time you're seeing them, it's very advanced, and it's even more complex, because now if they have a cataract in the other eye, they don't want anyone to touch, and maybe actually no one should touch. But that whole pseudophakic bullous keratopathy is just struck me that actually then it should almost be mandatory to do a cell count on the other eye just in case.
Yes, Dr. Kiba, I totally agree with that. Can I just interject and just add also that some of the pseudophakic bullous keratopathy, if they're caught early, you can do a DSEK and they do very well. The indication for a DSEK is just a round pupil, should not have a PI, and the lens should be sitting well. Because once you put the DSEK tissue, you need to put a really tight air bubble. And if you have a PI or it's at a phakic, the bubble tends to go behind. It's very difficult to do surgery that way. So if you have a nice AC, you don't have subepithelial scarring, please send that patient to somewhere where they can do a DSEK. They will do much, much better than then worsening to grade 4, and then it has to be a PK, which is a lot much difficult to deal with. So I think the other lesson here is, for bullous keratopathy, try and get them before they go to stage 4. Do a DSEK, it's much easier surgery, much better outcome in my view. And in our places where patients are very bad in follow-up, you reduce the suture complications in the PK. So that would be my advice.
But which centers are doing DSEK?
We started doing them in Lighthouse, the DSEK. I don't know whether Sony is here. I've talked with her. She does a bit of DSEK and I think PDEC, if I'm not wrong. So she's here, she can speak for herself, but those, I do know that we do some.
Okay, I just wanted, Dr. Nyamori is here. They did a study just to compare the endothelial counts, and I think Dr. Nyamori, I thought I saw him.
Yes,
you could just comment on that. They did it before and after. Please comment on that study and what you thought.
Yes, sorry. Yes, can you hear me? You can hear me?
Yes.
Okay. Yeah, Dr. Karagania, when you did that study,
Go
Dr.
ahead.
Karagania, when you did the study, Dr. Karagania, of course, the changes we did, the title was changes in endothelial cell counts before and after phacoemulsification. Of course, the key findings were that the endothelial cell counts were changing, but the corneal thickness is what was a bit paradoxical in a study. But of course, it was dropping down, and we stuck to the rule of 2000 should be the cutoff before you do phacoemulsification, I think, which is what was already in most common practice. But what we realized, most people are not doing endothelial cell counts in other centers. So we thought maybe this should be recommended as a standard practice among people who do phaco. And especially now that you're doing many elderly people and geriatrics. And now you hear, as Dr. Korir is saying, now the Fuchs, which might even be in the younger people. So, of course, the cutoff was around 2,000 still among the people who had been operated, because that was a practice. So we didn't have any who had been done out of that range below 2,000 endothelial cell counts before cataract surgery, because that was the rule at that center. So we didn't get any that was out of the limits. Unless there's a question, I don't know.
Okay, thank you very much. Cynthia says, seeing that OCT seems more readily available than specular microscopy, would it be an alternative? And just other comments, Tenwek also does DSEK. And then I'm putting this to you, Korir. How soon can DSEK be done after cataract surgery? I think that's one of the things you have discussed. So would OCT alone be an alternative?
I do
because
think
it's widely available countrywide, or must be done? Yeah.
Yeah, and OCT will not give you the details that you want. I mean, as I said, you don't even need an OCT to diagnose Fuchs dystrophy. You know, you see Gate, it's at the center, just on a slit lamp diagnosis. And as I said, it's symmetrical in both corneas. That you don't need an OCT, but OCT will give you the cross section, show you that you have, you know, a thickened, a bit decimates, you have bulle, which all these things you can see on a slit lamp. But an OCT is good when after you've done DSEK to see whether your lenticule is well opposed, or you need to go and rebubble, or you have something on the interface. That's the only role for OCT. It cannot do specular microscopy. No, it cannot replace it. How soon can DSEK be done after cataract surgery? One, you can do DSEK during cataract surgery. That's what is recommended. But if it is after cataract surgery, I guess it's just as soon as the eye is quiet and you think you need to do surgery, you can go back in. You know, you just need a tunnel, put in the lenticule, and you're good. And you want to do it before you get into stage 3. Yeah. Thanks.
Just one last question, because I think we're running out of time and our sponsors need to tell us what they have. Camera is asking for the centers offering specular microscopy. What does it cost? I don't know whether she means, Camera, is it the cost of the gadget itself or the cost of doing the microscopy? I think people will answer and tell you either on the chat or elsewhere. So let me hand over back to Frank. Thank you very much. Thank you very much, Korir, for an excellent presentation. Thank you very much for everybody.
Thank
you very much, Prof. Thank you very much, Dr. Korir. Now I want, let me introduce myself. I left myself, I didn't introduce myself initially. It was intentional. In front of my seniors, I didn't want to disrespect them. So I'm Frank Okada Nyakawa from Nyamira County. I'm an ophthalmologist. Now I want to introduce Annette. Annette, I'm afraid I cannot pronounce. I don't want to get into trouble by pronouncing your second name. Maybe you can pronounce it yourself. Yes. So Annette, she'll talk. She's from Malagan, and we want to thank you for hosting us today. Welcome, Annette.
Thank you very much, Frank. Let me start by thanking OSAEK for giving us, as Alagan, another opportunity to sponsor another meeting in this platform. Thank you, Dr. Korir and Professor Ilako, and all the doctors who attended this evening's meeting. So because of time, I can see we're almost running out. And as requested, I'll try and keep it short. We'll just do an overview of our lubricants, which most doctors are familiar, just maybe a mention or two on their brands. Just a minute. Okay, can you see my screen?
Yes, Annette, you can see the screen now.
Okay, so I'll start with the Optiv family range, which for even, I think today's case, probably lubricants are used. And as most of you are aware, for the Optiv range, it's recommended for the dry eye patients. And we do have the Optiv Plus, the Fusion, the gel, and the plain. And for the, we'll split them into two. So for the Optiv Plus, that would be for the lipid deficiency dry eye. For the Fusion and the gel would be recommended for the aqueous deficiency, Fusion during the day and Optiv during the night. I think my sharing has an issue.
No, it's okay, Annette, it's okay.
Okay, so probably I just mentioned all the others, and maybe my colleague Pauline to say, maybe respond to the anti-glaucoma that could be recommended to such a case. So the other steroids that we have from the company is Predfort and FML and neomycin, which is a multi-steroid. We also do have the plain FML. It's available in the market. Probably those who are interested to have it in their clinics, it's available, and you can contact either me or John, reach out, and we can always help you to make it available. And the antibiotic would be Exocin, which is an original of Floxacin, but I think for today's discussion of Floxacin would be a very aggressive antibiotic to use for this patient. And then finally, the Relestat, which is our antihistamine, and Atula and steroidal. So that would be it from me, but I think my colleague Pauline would like to mention a thing or two. Pauline, are you still on? Okay, probably she's not there. Okay, so thank you very much once again. That will be it from me.
Thank you very much, Annette. So now I want to give special thanks to Dr. Korir. We have reached now the end of our presentation. I want to give the special thanks to Dr. Korir. Dr. Korir is our president for OSAEK for that wonderful presentation. I also want to thank our professor, Professor Ilako. Professor Ilako, thank you for accepting to moderate this CME. I want to thank you for your extensive services and contribution to eye care in Kenya and beyond. We are indeed all your students. Alagan, I want to thank you for accepting to host and cater for this CME. Special thanks to Annette in particular. And also I want to thank for the team behind this CME. Our next CME will be on 25th of May this year. It will be on anterior segment. We'll share the topic as soon as possible, and also the presenters and the moderators. Thank you very much for attending, all of you. Welcome again. We meet again on 27th of May, God willing. This is the end. Have a good evening, a good night, and now you can leave at your own pleasure. Thank you very much.
Thank you. Bye.
Thank you.
Thank you.